Bonjour tout le monde. I'm going to start in French and turn into English after that. Okay. Bonjour tout le monde. On va démarrer, si vous en êtes d'accord. On est très heureux aujourd'hui d'accueillir le professeur Jongh de l'Université d'Amsterdam, qui est un grand spécialiste des stratégies de traitement des PTSD complexes avec des stratégies de Emdr dont il va vous présenter les grandes lignes. Et on a le plaisir aussi d'avoir comme discutant le professeur Wissam El-Haje, que vous connaissez tous et qui travaille aussi au sein d'un centre spécialisé dans le traitement du PTSD. So many thanks, Professor Jongh, to have accepted this conference, and the floor is yours. So if you can share your screen.
Now, thank you very much for the invitation. I like talking about the Emdr therapy. And yes, I'm also a trainer in the Emdr, an official trainer, but I also have a cognitive behavioral background. I now, in this presentation, I will give you an overview of the, give you a basic about the Emdr and what the possibilities are. So what we're going to do, I give you a small introduction. We're going to talk about trauma in general, PTSD, psychotherapies that are available for PTSD treatments. What is the Emdr? I'll show you a video clip, the working mechanisms. What people always wanted to know, how Emdr works is actually a funny therapy by moving the fingers before the eyes of the patient. So, but there are ideas how it could work. Emdr and treatment of severe comorbidities. I just heard that there is interest in telling more about severe comorbidities and how can Emdr be helpful in this way. I do a lot of work on personality disorders. There's no time to do that, but I will tell you something about our work in Emdr with psychotic patients. And then there's always nice to see videos of children, how they respond to Emdr, because Emdr is a very, very fast working therapy. And I think in many circumstances, you can do a few memories in one session. So in fact, you could treat PTSD in just a few hours. So, as to the treatment of PTSD, a range of trauma-focused as well as non-trauma-focused psychotherapies are available and show clinical benefits. If you look at meta-analysis, and there appear more meta-analysis on PTSD than there are trials. But if you pick just one, and after this many other appeared. But this gives a nice view on what's available, I think. Now, on the right side, you see the core of a meta-analysis, and that's the forest plot. And the forest plot shows you the difference between the zero line and the treatment effect. And here is the average effect size. So here you can see that the average effect size of Emdr is large compared to other treatments, but also compared to doing nothing. But if you look in the literature and you see the meta-analysis and all the trials that are available, you see that there is no much difference between the effects of the different treatments. So all treatments on PTSD that are evidence-based are equally effective, you can say. So that's nice, because there are a few treatments available, like trauma-focused cognitive behavioral therapy, Emdr therapy, and some of them appear in the guidelines. And I think in France it's not different than in the Netherlands. We like to have guidelines so that therapists can choose what is the best therapy for the patients, at least that there is enough evidence to do it. So if we want to take one of these guidelines, it's the International Studies of Traumatic Stress, the ISTSS, and these in their guidelines, there are strong recommendations for a few therapies like prolonged exposure, cognitive processing therapy, cognitive therapy, individual CBT with a trauma focus, and these are all all have appeared to be beneficial for patients and effective in scientific trials, in randomized clinical trials, and EMDR is one of them. But what is EMDR? And it all starts, if you read about EMDR, it starts with Francine Shapiro. And Francine Shapiro is the one who discovered EMDR in 1987. In 1980, the DSM contained PTSD. So it's a relatively new diagnosis. It's only invented in 1980. And 7 years later, and then it was a difficult disorder, mental condition to treat. Because if you look in the literature before 1987, a treatment for PTSD lasted about 40 sessions. And then Francine Shapiro appeared and she said, I did a discovery, I walked in the park, I did a discovery, and I think it's possible to do it in one session. So there are people that believed her, they want to have courses and wanted to learn this therapy. And on the other way of the line, there are the universities, and the professor at the university said that's bullshit. That's not possible. We normally do this in 40 sessions. This is not possible to do it in a smaller time. And we have never heard about EMDR. So, but Francine Shapiro was also able to do studies. So in 1989, her first study appeared, and it was quite convincing, at least. But yeah, she was the one that did the research. So there was still controversy about is EMDR a new therapy and that is effective or not. So that took a while before it came in the guidelines. Actually, when you look at it from a cognitive perspective, you could say what she discovered was that by keeping a memory in mind while the eyes move back and forth, the memory loses its emotional charge. And that's what we see all the time. When we do EMDR, we see that the memory shifts in terms of disturbance, emotionality, and vividness. So the memory degrades. And she wrote up a protocol because she wanted to teach it to other people. And in this protocol, there is a part in which the memory gets activated, and the patients, and when it's activated, the patients are asked to follow the therapist's fingers with their eyes. So it's a distracting thing what you're going to do. But if you look at this, and I'll show you some videos, it's a bit strange actually, because from that point that Francine Shapiro introduced this therapy, people were talking, had long sessions of talking. And then Francine Shapiro came and introduced a new therapy, and he said, let's don't talk anymore, but just think about the memory and follow my fingers. So, and distracting stimulus was involved here. And again, some people believed that it was true. Other people said, this is strange. I don't believe this. But nowadays, it's an empirically supported therapy. It's highly structured and a protocolized procedure. In the Netherlands, we have a protocol that's really describes word by word what you have to say as a therapist to the patient. So it's highly structured. And when we teach the procedure, we ask for the therapist to really read it. So there's not much leeway space, you can say, to use other words, because and that's also the way in which we investigate the procedure and its effectiveness. So highly structured in terms of wording and phrasing of what you're going to say. It's time limited. It's very quick and dirty. You could say, I have a clinic in the Netherlands in which we treat 150 complex PTSD patients per month. So, and yeah, yesterday I did with one patient 3 or 4 memories in one session. So it's possible, but you know, complex PTSD patient can have very much memory. So you still have time to treat it, but it's time limited when you consider it's in the way how many memories you can do in one session. It seems really easy when you look at it, but it's more difficult when you try to teach it to therapists. Largely non-verbal, there is not much talking, just only process instructions. So the key procedural aspects, but you will see it right away when I show you a video. First part is activating the neural network. That's what you also do in exposure therapy. So there's the mental representation of traumatic injury. So you ask the client to tell the story and to make a still picture of it. And when the still picture, that's the most disturbing part of the memory, you ask them to also state a negative belief. And that can be, I'm in danger, I'm powerless, I'm wordless, when it's, for instance, when it's complex PTSD. And that really activates the memory even more. You ask for their affect, so the emotions they feel and where it is in their body, and it's fully activated then. And then you start with the distracting stimulus, performing the eye movements. It's called the desensitization phase. And at the end, or yeah, more or less at the end, you also want to have a goal where you go to, and that's the installing of a functional belief. So the other thing, so I'm not in danger, I'm safe now. For instance, when it's I'm wordless, I'm worthy. And at the end of the procedure, people have a SUT of 0. If it works well, a SUT of 0, that's you feel no tension anymore when you look at the memory, you bring up the memory. And also the positive belief, for instance, I'm worthy, is fully true, feels fully true. So it looks like EMDR is efficient if you do it well. And that's also supported by research. This is an article that appeared, it's actually kind of meta-analysis, you can say, and it appeared last year. It's a cost-effectiveness study comparing all the different therapies that there are. And here on the x-axis, you see the quality of life, actually. When it goes from this direction, you could say the quality of life is added. And here on the the y-axis, you see what it brings you in terms of savings and costs. So here are the savings and there are the costs. So when you do nothing here in this green, when you do nothing, it doesn't save you anything, of course, and it doesn't give you anything back in quality of life. But if you go to trauma-focused therapy, trauma-focused CBT, you can see, yes, it's costly, it costs something, and it gives you back some quality of life. If you go to EMDR, you can say it saves costs. It doesn't cost much, but it saves costs, and it gives you a lot of quality of life also. So from all these therapies, EMDR is one of the most cost-effective therapies, you could say. It's quick and dirty and saves a lot of money. I like this table because here you can see all the different therapies compared. I've never seen such a table, but I like it very much. Here you can see the odds ratios, which means the likelihood to lose a diagnosis compared to doing nothing. So if you see EMDR, you can see that it's 42 times more likely to lose a diagnosis when you do EMDR compared to doing nothing. If you look at trauma-focused CBT, it's less. It's very good, of course, 14 times more likely to lose a diagnosis when you use trauma-focused CBT. But what is also very helpful, and it's very close to trauma-focused CBT, is self-help with support. What's not very useful is SSRIs. You can see the combination of, yeah, the psychotherapies here compared to the effect of pharmaceutical agents. So yes, very interesting. I like it very much. So you can see, yes, you should do psychotherapy and not giving pills. Conclusion: eye movement desensitization, reprocessing EMDR appear to be most effective, cost-effective intervention. This group of authors is not the first group that there is, because these are almost all people that are connected to the NICE guidelines. And that this didn't appear in the NICE guidelines, but it's really an addition to how you can look in it's not only in terms of effectiveness, but also in terms of cost effectiveness of therapies. Yes, how does EMDR work? Everyone wants to know, because Francine Shapiro waved her arms before the patient, but it worked, it seemed to work, but how does it work? There was a lot of controversies about that, but because the CBT people say, yeah, it's just exposure. You have to, you think about it, and you do these fancy eye movements. It makes it very mysterious, but it's still exposure, of course. But yeah, if you do exposure in very short times, then the SUT is not decreasing. It's mostly in between sessions that the SUT decreases, but not within session decrease most of the time when you do exposure, prolonged exposure. So Francine Shapiro, when she discovered this, she actually, what did she find? She discovered that performing an attention demanding task is capable of disrupting a visual image when it's held in mind. Her explanation was that it has to do something, it should have to do with the brain, she said. And so when she published her first article, the reviewers say, please explain, what do you think? And she came up with a neurobiological explanation. She said, if you move your fingers before the eyes of a patient, then you shift from one part of the brain to another part of one hemisphere to the other. So you're activating this bilaterally, this hemisphere and this hemisphere, because these because of the chiasma opticum, there's a cross of neural pathways when you do the visual, when you do a visual task. So if you use the eye movements before the eyes, then actually activating one half of the brain and the other. And when you do that, there was some anecdotal evidence that the corpus callosum would be active and transform information from left to right. So from, in her idea in that time, it was a connection between feelings and cognitions. There's not much support for her model, but she always liked her model. There's much more support. Actually, the most support is from a cognitive point of view. And very funny, actually, because in 1978, Francine Shapiro did her discovery and tried to explain it in neurobiological terms. But before, Alan Baddeley developed this working memory theory in 1974. And the working memory theory has a lot of support in terms of how you can explain EMDR. But if you apply to the EMDR therapy, you can say, when the memory is in the long-term memory, when you have been bit, let's say you're being bitten by a dog, and it's in the long-term memory, and you ask the patient to retrieve it and place it in the short-term memory here, and you add eye movement, there is a competition between these two tasks. The memory is in the working memory, and you ask them to follow the fingers with their eyes. So if you do that, it's distracting, and the memory loses its emotional charge. It's less disturbing, it becomes less vivid, And that's called reconsolidation. It's a very new term. So actually, Francine Shapiro was aware of that. EMDR can be called reconsolidation therapy in terms of when you bring up the memory, you keep it you place it in the working memory. Then you do another task. There's a competition between two tasks, and the memory is saved in the long-term memory again with less vividness and less disturbance. And this is what you do in therapy. You constantly repeat this cycle. And many years after Francine Shapiro discovered her therapy, then the first articles that appeared about this, which were more than 20 years later. And this was a team of research in Canada. It was also the first publication in a CBT journal, like Behavior Research and Therapy, a very famous journal in cognitive behavioral for cognitive behavioral therapists. And they showed that in 6 experiments, things happened like this. So here on the y-axis, you see this is the difference between pre and post. And so here you see the effect. If you do eye stashiness, you just look at a picture on of a dot on the wall. That's this condition. It's randomized, of course. And here you do the eye movements. Then you see quite a large difference. And this difference is not after an hour, but after 96 seconds. So what you do is you ask the patient to keep the memory in mind, you do eye movements, and here you see the effect. If you compare it to doing nothing, you see here the differential effect. So in terms of vividness, completeness of the picture, and emotionality. So that was very nice because it had such a very quick effect, 96 seconds. So many scientists after this publication started to do their own research, and they all found the same effects. What I like about the working memory theory is that you can explain it to patients. And we made this animation video for patients.
If you have experienced something horrible and have developed psychological symptoms such as flashbacks, fears, sadness, or sleep problems, you may well be helped by EMDR, a proven and effective therapy. Suppose you have been confronted with a violent crime, an accident, you have been bitten by a dog, or you have had to deal with sexual abuse or violence at home. Such a powerful experience is stored into your brain with a lot of emotions. Once such a memory is stored in your long-term memory, it can bother you for quite a long time. The disturbing memory keeps coming back unintentionally, for example, with feelings of powerlessness or believing you are not worthwhile. EMDR therapy can help you get rid of these complaints and feelings. At first, an EMDR therapist will ask you to activate the memory of this disturbing experience from your long-term memory. The memory is now stored in your short-term memory, also called the working memory. Then the EMDR therapist will ask you to focus on this horrible event. From there, the therapist will move his fingers in front of your eyes rapidly back and forth and ask you to track his fingers as best and as fast as you can. By keeping a traumatic memory in your mind and tracking the fingers of the therapist at the same time, the working memory gets to process a lot of information at the same time. As it is so much information, the image becomes blurred and loses its emotional charge. When the emotional charge of an image lessens, it also becomes easier to think differently about the experience. You will notice this because you feel less powerless or you feel worthwhile again. The intrusions have gone and you feel less anxious. You feel less depressed, you sleep better, and because you have managed to leave the experience behind you, you start enjoying life and looking forward to the future.
Again, this theory, it's cognitive theory, and many people understand. So it's in the long-term memory again, There's a competition between two tasks, the memory and the fingers of the therapist. The memory becomes less vivid, and there is room for positive changes, which also will be stored in long-term memory. And yeah, sorry, the severe comorbidities. We published a study in JAMA Psychiatry a couple of years ago, and that showed us this. We compared two therapists: prolonged exposure therapy, EMDR therapy, and a waiting list control condition. The waiting list control condition was very important because it was a difficult trial. The ethical committee, the medical ethical committee said, yes, you have to be very aware that the psychotic patients, they were all psychotic and had PTSD, they could, they compensate. So you have to be sure that that you stop the study when someone tried to commit suicide or something. I'll come back to that later. You see, schizophrenia is very potent here. You can see more than 60% has this diagnosis. They were all for a long period in time in mental health institutions for 21 years. And here you see 60% that has been sexual abuse, of which 38% were sexually abused by multiple perpetrators before the age of 12. So, and a lot of physical violence. So there was a relationship, you can say, between a background in terms of PTSD, in terms of trauma, criteria-worthy traumas, physical violence, sexual violence, and this psychotic symptoms. And here you see the effect of the therapy. Exposure therapy and EMDR therapy do very well after only 8 sessions. So this was a very good effect. After 8 sessions, therapy was very effective. And 60% lost their PTSD diagnosis after 8 sessions. So comorbidity didn't play a big role. Here you see the CAP scores, so the PTSD scores over time. This is published in the British Journal of Psychiatry. You see the 12 months follow-up. It's a straight line. So here are the 8 sessions. There is no coming back of symptoms. People could have had more sessions. This is what we expect if you would have done more sessions. The delusion, so that was a by effect actually, but here you see a reduction of 50% of the delusions when you treat PTSD in these patients. And that was magnificent because we thought this is 8 sessions. What would have happened if we used 16 sessions? Will these, the double number of sessions, would that have led to 0 psychotic symptoms in terms of delusions? And that's what we're doing right now. It seems to be a very nice study is running right now, a large study again, in which we do 16 sessions and we compare cognitive restructuring, EMDR therapy, and prolonged exposure, and see whether we can really wipe out the delusions if we do a longer period of time. What is important, because this what we expect of what the medical ethical committee expected is that these people would drop out or deteriorate. The dropout rates are very low, are below normal PTSD studies. So comorbidity doesn't seem to play a large role in terms of dropout. But these serious adverse events, here you can see EMDR, one series of serious adverse events. So one person tried to commit suicide. But this is the waiting, that's the treatment as usual. 4 times more. So what everyone expected, that when you would do EMDR, these people would deteriorate. But that didn't happen. It's the other way around. Dus the people that had the normal treatments and the normal medications and so on had were 4 times more likely to commit suicide, or at least doing an effort to do so. So this is very interesting. This is what we see. This is what the psychiatrist did. This is what psychiatrists do, and this is what the psychologists do here in terms of treatment, psychological treatment, added to the medication that they already have. Is Emdr also effective for children? Yes, also a very nice trial, a large trial we did in the Netherlands. Emdr compared to CBT, cognitive behavioral writing therapy in a weightless condition. In 6 sessions Emdr and cognitive behavioral writing therapy, 45 minutes each, 6 sessions, and a 92% loss of diagnosis for these children. CBT also did quite well. There was actually no effect in terms of effectiveness, and no difference. But if you look at the treatment time, we use a stopwatch. In every trial we use stopwatches. So all the talking and going to the toilet is taken out. And then you see that it's only 2.4 hours you need to treat someone with PTSD when it is a child, compared to 3.8 hours, which is still good. Still good, but here you'll see that Emdr is quite efficient if you compare it to other therapies. And also for the long-term effectiveness, you can see it's stable when the reduction has taken place. Patients stay stable. So yes, again, the main conclusion, Emdr is a first-line evidence-based treatment for PTSD. The advantage is not only its effectiveness, but there are other therapies that are effective, but it's particularly the cost effectiveness. 3 sessions for a single PTSD, like say 2 hours, is possible. Emdr has been found to be effective for PTSD in children, for memories of childhood abuse, complex PTSD, and in case of severe comorbidities. And we're doing studies on personality disorders, on pain, on depression. And it seems that if there is a core background of memories that's fueling symptoms, could be anxiety, could be PTSD, if you take out the core, then the symptoms decrease. Yes.
Thank you very much, Ad. This was very didactic, so it's very interesting. For the audience, you can ask your question within the Q&R window. We can get them.
Yes.
In the meanwhile, I can ask you many questions. One of them would be, PTSD is frequently associated to dissociative symptoms. You know that DSM-5 described also the dissociative subtypes of PTSD. So what would be the impact of Emdr on these dissociative symptoms? And would you recommend Emdr in more severe dissociative situations?
Yeah, I think you have to see PTSD. There are several symptoms like hyperarousal, intrusions, and you take them out. You also take out the symptom of dissociation. And maybe I can show you a slide that we, from a study that we did here. Also a meta-analysis has appeared this year, showing there is no negative effect of dissociation when you do Emdr of another type of therapy. This is a question we had. Do intensive treatments that being in a program are also effective for those that has the dissociative subtype, depersonalization, state of consciousness in which the person feels unreal, and derealization in which the person perceives the world as unreal. And here we published this in 2018, showing that there was actually no difference between those that had a dissociative subtype and those who did not. So there was no interaction effects. That means the treatment program that we had, so it was exposure and EMDR combined, was equally effective for individuals with the dissociative subtype of PTSDs and those without this condition. So you really have to see dissociation as a symptom of PTSD, which disappears when you do your treatment. And it's no complex. But I know many therapists are afraid of it. I don't know why, because people are not afraid for hyperarousal, but therapists are afraid of dissociation. Why? I don't know.
We have two questions. One of them is, was EMDR tested in different disorders? I think you already said about depression and anxieties.
Yeah.
And another question is about protocol of EMDR in more severe patients like bipolar and psychotic. You gave the example for psychosis.
Yeah, for bipolar, there is also evidence. Yeah, you have to see all these symptoms, all kinds of disorders, when it's panic disorder or it is bipolar disorder, you have to consider them as a set of symptoms. And if you find the core, if people are not born with these symptoms, these symptoms develop because of happenings in their life, because they were beaten up, because they were left alone, nobody cared about them, and there are all events. People know that, because when they think about these events, they feel never the negative effect of it. And if you want to alleviate these negative effects and the negative symptoms, the symptoms of depression, for instance, you have to go to the core and treat the symptoms by treating the memories.
Would you say there's any contraindication for patients suffering from psychosis with trauma and to use EMDR?
No, actually not, because we took every patient in. There was actually only acute, that's also in our clinic, the only thing we don't accept are patients with acute suicidality. So people have to be free of suicide 3 months before they enter the clinic. And that's what we also do in the studies, because otherwise you have to manage their suicidality ideation.
Would you say that efficacy of EMDR is related to how old the memory is or the event is? Is there any time link?
Well, no, yeah. When there is something in their life that fuels the symptoms, like depression. Yeah, we did a very nice study in depression in adolescents. We just conceptualize it by going in through their life in a timeline and see what were the events that they feel depressed about. And that were the self-damaging events, the self-worth that really proves that you are not worthy. Yeah.
We have very technical question and interesting. It's about the importance of the bilateral movements, and if we can substitute with another attention bias movement or anything that would alter the attention.
Yeah. We do a lot of research in that. In laboratory studies, we published a lot about that. And actually, you can take everything that demands attention. So eye movements is just one of these, but it's quite, if you look at me, I don't know whether you can see, and you try to follow my fingers. We do a lot of treatments just online. This is distracting stimulus, but you can also use other types of stimuli like tapping. You can also do sounds on your ears. I ask them sometimes to make steps in the room. From research point of view, you can see you can take everything that demands attention to reduce the memory when it's kept in mind. So there's no difference between eye movements and other type of distracting stimuli.
There's plenty of questions. Maybe one last question. Would you tell us something about post-traumatic complex personality compared to borderline personality?
Yeah, if you mean that complex PTSD is a set of symptoms, and the symptoms are really similar to what we call borderline personality in the past, and still call it that way. So what we did in a study, in a randomized clinical trial that's just published last year, in which we treated all types of personality disorders. They all had a symptom decrease, which was quite big. And also in our clinic, we do the same. We treat the complex PTSD and we look at the symptoms of borderline personality disorder. The problem with the borderline personality disorder is that you have to wait 1 year to diagnose them again, and that's what we're doing right now in a randomized clinical trial. But if you look at here, I want to show, if you have 1 second, I can show you the slides of our borderline effects study. Here, that's what we published about. You can find it in the European Journal of Psychotraumatology. So all kinds of symptoms you can treat by treating the trauma. Huh? That's the idea. Here you see the borderline effects. Similar lines for those who have a high level of borderline personality symptoms compared to low borderline. You see parallel lines. And what we found is that 33% of the patients lost their diagnosis based upon the positive screen of the BSL. Yes, and we had no dropout and no adverse event. Actually, that's interesting when you compare to the Boho studies, that in 8 days we had the same or similar effects as a study that took one year in Boho's department. So that's very interesting. So we are on the brink of have new possibilities of treating the old ideas of personality disorders. See it as a set of symptoms that disappear when you treat the traumatic events underlying the condition.
Thank you very much. That was a great talk. Many questions, very interesting. I hope we can continue discussions in future conferences and maybe create collaborations with the help of FondaMental. That would be great.
Yes, if you are interested in, for instance, establishing a clinic as what we do, so the intense treatment, only 8 days of treatments, that's what had the 33% loss of diagnosis in 8 days on borderline. If you want to find us and see how that works in a clinic in which we treat 150 patients per month in a very dynamic way, because we also change every session with another therapist. That's therapist rotation is also a new element in it. If you want to see it, you're always welcome.
See it, yeah, would be great. Marion?
Well, thank you very, very much to both of you. Thank you very much, Professor de Jongh, for an excellent conference full of real history of psychiatry. So it was really great to see these films and full of future ideas. So it's really impressive how fascinating this field is moving on. So thank you very, very much. And I hope we can establish collaboration as we discussed before.
Of course. Have a nice day.
Thank you. You too.
Bye-bye.
Bye-bye.